Okay, so good evening, ladies and gentlemen. My name's Neil Loach. I'm the president of IOH, and this is our final webinar for the series of 21 for 2021. And we've actually gone one better. We actually have done 22. So even though we planned to do 21, we've actually done 22. So I'm delighted to welcome Jane Johnson. Jane is an MSK physio clinical lead for PAM Wellbeing. And she's been with PAM, I understand, for about 2.5 years. So I'm going to hand over to Jane. And thank you very much.
Thank you for that. I'm delighted to be here. I'm told that your webinar presentations, they can last an hour and 15, an hour and a half. I think this one's not going to be as long as that because it's a very specific topic. I've tried to hone in on the things that I think are going to be most interesting to you, most useful to you in your practices. So I've got a couple of illustrations for you. I've got about 30 slides. So if you're thinking, oh, we'll be getting to the end yet, you know, tell by how many slides that I've been through. So I'm going to share some little case histories, some of the cases of Cauda Equina I've come across, and hopefully maybe you'll all, you learn something that you didn't know before. I think it's a great opportunity in occupational health to learn about Cauda Equina because most people who develop this, they actually have low back pain. So they come and they get referred into occupational health with low back pain. And as you'll see as we go through the webinar, there are some symptoms which can be quite vague with Cauda Equina. I'm going to tell you what Cauda Equina is and how you're going to be able to identify it and what you could potentially do about it. So in occupational health, we're right at the coalface, aren't we? We're right there, right at the start when someone comes in to see us, they've been referred into our service, and we have the opportunity to identify these people and potentially save them from a lifetime of disability. And you think, well, oh, that's a bit dramatic, Jane. Why being so dramatic? Well, when you see what Cauda Equina can do, what the symptoms can be, you'll realise I'm not being dramatic at all. So let's pull back our curtains and see what we're going to cover. So what sort of questions is the webinar going to answer? Hopefully, what is Cauda Equina syndrome? Where is the Cauda Equina and what is its function? What causes Cauda Equina syndrome? What are the symptoms? Why is it a medical emergency? If you read the literature, it'll say it's a medical emergency. It's a medical emergency in my experience, but it's not rare. Lots of people say it's rare, and I don't think it is because I come across it quite often. I'm going to give you 3 contrasting case histories, just very briefly, and explain what we should do as clinicians. So if we think, oh, someone might be having this, they come in with back pain, but actually there's a few other strange things going on. What should we actually do? Do we just make some clinical notes and send them away? Or do we just send them back to their GP? What do we do with these people? And of course, I've just given you some resources at the end, and I think you'll find those very, very helpful. I've picked the key resources that I think, if you had to choose just 3 or 4, which ones would you go to? And there's a lot of information out there because obviously that we've known about this condition for a long time, but hopefully you'll get a lot out of those resources. Why have I got a big horse's rump on the screen? And that's because Cauda Equina is Latin for horse's tail. So it's just like that. We have this lovely group of nerves coming out of the base of our spine, and they splay out like that lovely horse's swishy tail. Obviously, ours don't swish about inside of us, but they kind of look like that. If you look at the illustration on the left, here they are coming down and exiting our sacrum. So you can see down here, the little nerves are coming out. They've chipped away some of the sacral bones, so you can see them, and they've gone through our sacrum there, right at the base of the spine. And you can see down here, there's your coccyx, the bit that we're all maybe sitting on at the moment. Today, I was standing up all day because I stand up all day when I'm treating. I've got a standing wooden standing platform that I use that I love. So at the end of the day, I sit down. But obviously, coxodynia is another issue that I've suggested that I might do a presentation on, because that's a very, very common problem, more so now, isn't it, with everyone or large numbers of people working from home. So pressure on the tailbone, and what can we do about that? So it's the Cauda Equina, a condition affecting the nerve roots at the end of the spinal cord, a medical emergency, and supposedly rare. And I come across it a lot, and I think it's because that it just happens that I work for PAM Wellbeing, an occupational health company like many of you, and I treat a lot of people who have manual jobs. And when you see what might cause Cauda Equina, you'll see why there might be a relationship there with manual labour. Here's the lovely Cauda Equina drawn out again. What's its function? It looks a bit spooky, that one on the right, doesn't it? I don't know, it reminds me of some sort of strange sea creature, something you might find in the depths of the sea, that they're going to say, oh, we've discovered this new strange creature. So the function is to provide innervation to the lower limbs, to help our lower limbs to work, to get them to work, our muscles to activate and to help us to walk. To provide innervation to the anal sphincter. To provide innervation to the urinary sphincter. To provide innervation to the skin around the genitals and the bottom, and sexual function. Symptoms of Cauda Equina syndrome, one of the commonest symptoms is saddle anaesthesia. So this is the saddle region. So if you imagine, as it happens, because I am sitting down now, it's the end of my day, I've been standing up all day, I've got a variety of different stools and seats, because as you know, it's good to change what you sit on as just as well as it is to change from standing to sitting and moving around. So I happen to be on a saddle stool right now, got a really cheap one, which I perfectly fine, absolutely love it. And the bit of my body that's on the stool is the bit that's in that illustration. So the bit that's in yellow is kind of the bit that's on the saddle stool. And we need to know that, because when we're asking people questions, and I'm going to come on to them and show you the kind of questions we really need to ask people to work out if they've, they're at risk of Cauda Equina. One of the things we have to ask them is, do you have any altered sensation in your saddle region? And they think, well, what's my saddle region? They wouldn't know. So the way you could describe it is, if you were sitting on a horse, the bit of you that's touching the saddle, have you got any strange sensations in that region? Another symptom is pain on the back of the legs, and you can have sciatica in one or both legs. Altered bladder function, altered bowel function, and we're going to go into these in a little bit more detail in a minute. Loss of sexual function. And the symptoms can be subtle, vague, and they do not follow necessarily a recognised pattern. And many people have potential Cauda Equina, or they end up with Cauda Equina, and it gets missed. And it gets missed because they go to see different people, and the people maybe don't ask them the right questions, or they ask the right questions, but the person, the patient, the employee doesn't understand the significance of the question. They don't realise how important it is, or they're embarrassed to answer them, or maybe the clinician's embarrassed to ask them. So you get a very not a clear picture, and I've got a very good example of one that isn't a clear picture and what I did about it. So that's one of the little examples that I'm going to share with you. So why is it a medical emergency? It's a medical emergency because a delay in surgical innovation can result in irreversible damage to the lower limbs, to the bladder, to the bowel, and sexual function. What causes it? Well, the illustration on the right there, that's a herniated disc pressing into the Cauda Equina, the tail that's coming out of the base of the spinal cord, that lovely horse's tail. So 45% of Cauda Equina cases are because a lumbar disc is pressing into the Cauda Equina. But anything that presses into the Cauda Equina, that group of nerves, can give you Cauda Equina syndrome. It could be a spinal fracture. It could be a spinal mass, something growing on the spine. It could be a spinal stenosis, a narrowing of the spinal canal. And it could be surgery. And in fact, last week, I had a case of someone who, unfortunately, they had gone to the doctor and said, I've got these symptoms, and the doctor thought it was mild low back pain, maybe with some sciatica. The symptoms became markedly worse, and the person went to A&E because they were having some problems with their bladder and bowel. And nothing was done at A&E. They were told to take painkillers. We're not going to x-ray you. It's not a problem. It's probably just sciatica. It's very bad. I know it feels bad to you. And they were sent away. And the symptoms worsened again. They went back to A&E a second time, and they were rejected again from A&E. And that's very unusual. And they went home again. The person was a lady, could walk, and she went home. And not long after, she woke and couldn't feel her legs. And her husband called the GP in the morning and said, "Oh, I've woken up and she can't feel her legs." And the GP sent her immediately to A&E, and they did an MRI scan. And when she came out of the MRI scan, they took her straight to surgery. But when she was referred to me, she still had bladder and bowel dysfunction, and she could hardly walk. She could walk, but with an aid and with the aid of her husband. And she'd had surgery. So the prognosis for that lady, unfortunately, is very poor. So that's why, it's much better to err on the side of caution if you think it is potentially a Cauda Equina, to send the person to A&E. But the point here is that because it can be, many of them are caused by a disc. As we know, disc herniations can give you radiculopathies. They can give you sensations in your legs, like the sciatic symptom. So it's understandable. It's a very difficult condition for some people to diagnose, because it can be a mixed picture. It can be quite a cloudy picture. So how common is it? Who gets it? Well, we're told it's rare, but anyone can get it. So hopefully with the examples that I'm going to give you, you're going to think, well, there's some young people that got it. It could be an older person. It doesn't favour anyone. Anyone can get it. It really doesn't. There is no particular pattern here. There are 4 stages. So you can categorise it. You don't need to categorise it. And the first one is the one that most of you may have come across, or if you haven't yet, you'll probably come across someone in this first stage. And this is where I think in occupational health, we really can help pick up some of these cases. So this is where Cauda Equina syndrome is suspected. Patients who do not have Cauda Equina symptoms, but who go on to develop them. So it's really important when you're asking people these questions, that they understand the gravity of the condition. And I often speak to my colleagues about this, and we have conversations. And because I'm a clinical lead, I field questions from colleagues, and they'll ring up and they'll say, "I've got someone, I've just come off the phone. Do you think I should send them to A&E? What should I do? What's the situation?" And we'll talk it through. So it's really important to talk to your peers if you're not sure about something, and get some advice on it, because what we need to do is we need to get someone seen very urgently if you think they've got Cauda Equina, so usually within 24 hours. And there is a credit card that I'm going to show you. It's a sort of a credit card shaped information leaflet. It's the size of a credit card deliberately, and it tells people what to look for. And many of you might have seen these. They used to be in clinics. We used to hand them out, and they are electronic. And I'm going to give you and tell you where you can get them from, and you can get them in all different languages. I'm going to give you an example of one in another language. But I've come across lots of people, and they've fallen into this category. And it might be just that I've come across them because I treat a lot of people who do manual work. And in manual work, you're at very high risk of, herniating discs, unsupported forward flexion. When you bend over and twist, that's how discs love to get herniated. So if you want to herniate a disc, lean forward and turn to one side, preferably while carrying a heavy weight, and then you're likely to herniate a disc. If you don't want to herniate a disc, don't lift that way. Be much more careful with your lifting. But this is the credit card, which I'm going to show you, is one of the really useful ways that we can intervene in occupational health. Another stage is when it's incomplete. So these are people who they present with urinary difficulties. They have, it's not because they've got a bladder infection, it's of neurogenic origin. There's something wrong with the nerves to the bladder. So if you remember the Cauda Equina, those nerves not only innervate our bladder and our bowel, our lower limbs, but our bladder and our bowel. They might have a loss of a desire to void, to go to the toilet, or they might have a very poor stream. It's sort of trickling when they go to the toilet, and then even to strain to empty their bladder. They might have loss of urinary sensation. So sometimes they might not, not realise that they can, when they're weeing, they can't feel it, they don't know it, they can hear it in the bowl, if you know what I mean, but in the toilet bowl, but they're not sure that they're weeing unless they can hear it. They can go on to develop it, and they are a medical emergency. So they need to have surgery to be what's called decompressed. They need to have the pressure on the Cauda Equina taken off the Cauda Equina, because they're a very risk of having a poor prognosis. We have this one, retention. Patients who present with painless urinary retention and overflow incontinence. So the bladder, in other words, is no longer under executive control. We can't control our bladder, and they have to have surgery, and it should be carried out, as soon as that can possibly be done. And finally, we have a complete Cauda Equina. So that person has lost the functions of the Cauda Equina. So they've lost the ability to move their legs, they've lost the ability to have control over their bladder or bowels, and they've lost sexual function. And I'm going to give you an example of that, because that's a very easy one to identify, because that person, if they got referred to you, it would be known that they have, Cauda Equina. It'd be very obvious. Those were the guidelines from the Chartered Society of Physiotherapy. They came out in May 2017. But as I say, you wouldn't have to categorise people, and you'd probably be working with people in that first categorisation where you're not really sure, it's a bit of back pain, it's getting worse, they've got some sciatica, and then they start to develop unusual symptoms of bladder or bowel, or they're embarrassed to tell you. Now, another example I had, again, this was last week, a gentleman who appeared to have sciatica, very bad sciatica and very bad low back pain. He'd had a few issues with his bladder, and he'd gone to the doctor with the bladder issues, and the doctor wasn't really sure and thought it was probably okay. And when I was speaking to this gentleman, and I'd finished the consultation and I'd been through some of what we call our red flags, which I'm going to show you, he said to me, but there is this other thing. And I said, what other thing? And he said, I've got this strange sensation around my anus. I said, what do you mean? And he said, it just feels really strange. It's kind of numb, but I don't have it all the time. I said, what do you mean don't have it all the time? How often do you have it? He said, well, most days, but not every day. And then he said, sort of, I might have it most of the day, but not all of the day. I said, have you ever had that before? Is this something you've had before you had your back injury? He said, no, only since the back injury. So that's for me, that's a red flag. That's a problem. That this gentleman has gone to the doctor. He's developed a bladder problem that isn't related to having, say, a bladder infection or some medication. He's got, a potentially herniated disc. He's got sciatica, and now he's also got something going on in that saddle region. So that's a good example of another case where, we really need to keep an eye on this gentleman. And this is just a reminder, again, of the functions of the Cauda Equina. So if it goes wrong, if it's, it stops working, if we press something into it and stop it from working, this is the worst case scenario. You could be, or the person could be wheelchair bound, but the good thing is, if we get there soon enough, we can actually, most of the time, we can prevent that from happening. Now, I've put this in front of you because these are some confounding factors. And this is, again, why, it's no one's fault that these things get missed. It can be very difficult to identify. These medications on the left, the opioid salts, the anticonvulsants, the antidepressants, the non-steroidal anti-inflammatories, and there are some examples of each category in the middle. They give you that you can have these symptoms, but these are possible Cauda Equina symptoms also. So, for example, tramadol coding, you can have constipation, as many of you probably know. You can have reduced bladder sensation. With naproxen, you can have retention, it's twice as likely in men than women, so you can have urinary retention. So when you're on these medications, and certainly if you're on them for a long period of time, you can have other things going on that will cloud the picture. So that's why we often take a drugs history, isn't it, when we're assessing someone, because we're trying to form our own opinion, and for many of us, our own diagnosis as to what's going on. So what must we do as clinicians? So if you're a frontline clinician and you've got someone coming, have been referred, for example, with back pain, what must we do? There's a little kind of credit card picture there of the document that we give out, and I'm going to show you that larger in a minute. It does really look tiny like that. It is a sort of a credit card, deliberately so people can keep it in their wallet. So what must we do? Well, we need to take a detailed case history. We need to explain that we're going to ask some really important questions. And one of the things that came out of the research, and you can listen to this in one of the references I've given you, when people were when they were assessed, people who had Cauda Equina, what they fed back to the researchers were that they had been asked questions, but no one had actually said to them how important those questions were. So if you don't think a question is important, you might think, well, I just can give a vague answer. If someone says to you, this is a really important question, I need to think very carefully about the answer, you know, because it helps me form my opinion of what might be going on, they might answer that differently. So it's really important when you're asking the questions that you find a way to express that. And again, I have conversations with my colleagues about this, because we think, my goodness, we don't want to put the fear of God into people, you know, and what if it is just this as opposed to, you know, a full-blown Cauda Equina developing, you know, and what do we do? And we always come to the same conclusion, that it's much better to err on the side of caution than not, because of the severity. This isn't something that's going to leave you with an itchy arm for the rest of your life, you know. So you know, that's what we all as clinicians end up sort of coming to the conclusion about. So again, we ask these difficult or embarrassing questions, and we need to get clarity from the patient. So if you're not sure, again, you need to drill down a little bit. Like, you know, this gentleman, you know, it's obviously a bit embarrassing, you know, talking about a sort of strange sensation around his anus. You know, we're different genders. You know, he might have been more comfortable talking to someone of a male gender. We don't know. You know, but he was a bit embarrassed. This came out right at the end of the conversation, even though I'd already asked him the special question. So clearly, you know, he had some reluctance to talk about that, as most of us would do, you know. But we do really need to get clarity and be quite specific about it. And even when I talk to my male colleagues, and they've been assessing female patients, female employees, again, they're really good at it. There's no holds barred. They're still really clear with their questioning with that person, and they get clarity as well, because they need to reassure themselves as a clinician that they're doing the right thing. So if we suspect Cauda Equina syndrome, we need to explain to that patient, to that employee, why it's so serious. What are the, you know, why are we saying you need to go to A&E? Not next week, or, you know, book an appointment with your doctor, or try and get your friend down the road who you think might be a physio to have a look. Go to A&E now. Why is it important? It's because potentially it has some very serious effects. And this is what we do. We say, go to A&E, call 111, at worst, call their GP immediately. But it's much better if they go to A&E, because what we do, and what I'm sure many of you who are treating people who've come across this, is try and reassure them that they will be taken seriously. The example I gave you of the person that was turned away from A&E, that's not, I wouldn't say that's common of the number of people that go with suspected Cauda Equina. I think it's probably quite unlikely. I don't work in A&E, so I can't really give an opinion on that. But of the people who I've treated who've developed Cauda Equina, or it's been caught in time, they have been treated very quickly. They've had an MRI scan straight away, and those who've had surgery have had it very, very quickly. So I try and reassure the person that no one's going to, everyone's going to take them seriously, you know, when they go there. And then finally, this is another thing that's really important, isn't it? We need to document in the clinical notes the advice that we've given someone, and that's because this is could potentially leave someone in a wheelchair. It's potentially life-changing. People can get very angry about not having been diagnosed early enough, or for there having been problems with surgery, and for all kinds of reasons. Some of that could be very genuine, that though genuinely things were missed. But there are quite a lot of cases where there's litigation involved. So it's really important that we have documented. And again, I've got an example of one of my tiny, very brief case histories for you, of where someone didn't want to follow my advice, and I've documented that. because if I have to stand up in court and I get asked, why didn't you tell that person that this is potentially serious and say they had to go to A&E, I can say I did, but they declined my advice, and this was the reason they gave me. So I've got that documented. And at the same time, you know, it's really good. I will always document, this is what I did with that, as you would with anyone, wouldn't you? You'd write in your clinical notes, what is it you actually did with that person and how they responded to the information that you've given them. So this is on the first side of the little credit card. It says common back pain. And it just says many patients have a combination of back pain, leg numbness and weakness. These symptoms can be distressing for you, but don't necessarily require emergency medical attention. A rare but serious back condition, Cauda Equina syndrome, can lead to permanent damage or disability and will need to be seen by an emergency specialist spinal team. See the other side of the card for some warning signs of Cauda Equina syndrome. So this is on the card that we would normally hand out to someone, or now that I'm working remotely, I give them electronically. So these are the warning signs. And you can see there's a big red box there, and it says if you get any combination of these, seek help immediately. So in other words, go to A&E. And it's listed out some of these things like loss of feeling or pins and needles between your inner thighs or genitals. So that's that sort of saddle region, the numbness in and around your back passage or buttocks. Remember that gentleman who said he had that strange sort of numbness, strange feeling around his back passage. Altered feeling when using the toilet paper. So that's quite a useful way that you can assess people. You can ask them, you know, when you go to the toilet and you wipe yourself, can you feel that you're wiping yourself? And then I go, well, no, not since I've had my back pain. Well, that means they've lost sensation there. But it might be that there are confounding factors. Another example is someone I spoke to. Again, he was actually a frontline that deals with assault, people who he gets assaulted, or his profession, they get assaulted quite regularly. And this person had certain symptoms, but actually, when I asked about the case history, it happened. They've been having some of those symptoms before the back pain, and the symptoms were related to were psychological. They were related to severe trauma because of what happened to this person. So they were actually not related to the potential for Cauda Equina. But that's why we always take case histories, isn't it, to try and get a clearer picture. What's a red herring? What's a potential red flag? But you can see there, can't you? If some of you have probably been reading that as I've been talking, that they've got all these really important things on there, like leaking urine or recent need to use pads. Well, you might have someone who, for various reasons, is leaking urine or needing to use pads that's not got Cauda Equina, not got an issue there. They may be, you probably think that commonly following giving birth, there's some leaking of urine. So commonly with older adults, there's leaking of urine. That's common, and so you would need to determine, wouldn't you, is this likely to be a factor related to Cauda Equina, or is it something that's unrelated to that? So let's do a quick case history. This is a really simple one-page case history for you. And these are all real. These aren't ones I've made up. And like I say, I don't know why I seem to attract all the Cauda Equina cases. It might be, I was thinking, is it because when they're getting triaged into my diary, that people realise, oh, Jane, she's a clinical lead, and put them with her. But actually, when I look at the referrals, it's not on the referral. It's because it hasn't yet been diagnosed a lot of the time as Cauda Equina. Most of the time, the person is referred with severe back pain and sciatica. This was slightly different, so I'll show you this one. There was a young man. He was 32-year-old. He had a manual job, very manual. He was referred into occupational health for a phased return to work based on it. They were expecting him to go into a desk-based role. And this was because they actually knew that he had Cauda Equina. Now, and this is insignificant, but here he had a very young family, so 2 toddlers and an older child with a recognised mental health issue and aggression. And his wife was 10 years his junior. So I'm going to come back to that. He'd had this recent history of back pain, no real trauma. He said he assumed it was sort of part of his job. He had this severe back pain getting out of the car and at his mother's house. So this is the history that I took from him. Manual worker, not really had any trauma, just said back pain was ongoing. He thought it was all part of his job. And then one day, getting out of the car, going to his mum's, his back seemed to be really bad, really severe. He said, well, I'll have a hot bath. He got into his he didn't live with his mother, but he got into the bath because he couldn't get rid of the pain. So he got into a hot bath to try and ease the pain. And then he realized he couldn't feel his legs when he was in the bath. He was very strong because of his manual work, so he was able to call for help. So he actually pulled himself out of the bath and he called for help. They called the paramedics. It wasn't diagnosed as Cauda Equina. He was delayed going to hospital. He had emergency surgery, but the outcome was that he was paraplegic. It wasn't caught in time. So this was a presentation where it was all very, very sudden. And in this particular case, the difficulty was because it was during the pandemic and there were issues in trying to physically get him into a hospital. That was the problem, the hospital that they had to get him into. So that, everyone was trying their best, but I think there was an air ambulance involved and, it was a really challenging situation. So what happened? He's doubly incontinent. He can stand for a period of 1 to 2 minutes with a walking frame. He's a wheelchair user. He's had repeated thoughts of suicide, but he's had ongoing psychological support. And he was really buoyed up by thoughts of a return to work in a desk-based role. And at the time I assessed him, he was very well supported psychologically, and his great sadness was because his wife was 10 years younger than him and he didn't want her to be his carer. And because one of his children was had aggressive tendencies, that child had to go and live away from the family home, because now that he was in a wheelchair, he couldn't moderate that situation. So there was a lot of, trauma. So you can see that's an example of, almost what you might want to call a worst case scenario. So he's an example of a complete Cauda Equina syndrome. It's complete. This was the one, the person that declined advice from me. So this one was a 40-year-old female and happened to be a paramedic in a desk-based role who had a BMI over 40 and was referred into occupational health with chronic low back pain causing multiple absences. And all of the red flags were present for Cauda Equina. And I'm going to show you my little, not for this particular person, obviously, but I'm going to show you some clinical notes where I've ticked some of the flags so you can see how that might look. So she had all the flags for Cauda Equina. She confirmed, I've been diagnosed with Cauda Equina. I advised the patient she needs to call 111 because at the time of my consultation with her, I thought she was at risk of developing this worse than she had it. She declined, stating that they'll only send an ambulance and I don't want my colleagues taking me to hospital. I checked that she understood what Cauda Equina was and what were the consequences, and she did. She convinced me that she understood what they were. And so I documented that in my notes. I was satisfied that she understood. So she was making a personal decision that she wanted to risk that rather than have her colleagues be called out to her. So it's incomplete. She's not yet got Cauda Equina, and hopefully she won't ever develop it. And again, this is a good example here. I'm going to give one just some clinical notes where they're subtle, they're vague, they don't follow a recognised pattern. This is one where a person was referred to back pain, and you'll see there were some issues. This is one of the sections of the red flag questions that we ask where I work. So most of the physiotherapists watching this, they'll know that they'll ask these questions. Are there neurological symptoms in the lower body? Do you have any bilateral numbness in your legs? Do you have any altered sensation in your saddle region or saddle anesthesia? And again, we can elaborate on these as we're going through the questions. Have you had any bladder or bowel disturbance? Have you had any sharp stabbing pain in your legs or extremities? Have you got localized low back pain? Because you can actually have these symptoms and not necessarily have localized low back pain. And of course, does it hurt if you cough or sneeze? And many of you watching, listening to this, you might think, well, they might have these symptoms if they had a disc herniation. They might have those. They may not have saddle anesthesia, but they can have, you know, in some cases. So again, these are the sorts of questions we absolutely have to ask. Those are mandatory. They're really important. And here's an example. So this is a section of some clinical notes. Obviously, there's no information you can identify this person. They were referred with just low back pain. That's all it said. Not had any injuries, low back pain. And I remember this person very well because they did not have English as their first language, and so we had to use someone to interpret. And it was a gentleman who did repeated bending. So they were stacking low shelves, and that's what they did, and they'd done that for years and years and years. The low back pain, and on its best, it was about 4 to 5 out of 10 on a numerical pain rating scale, and at worst, it was 7 to 8 out of 10. There'd been sort of on and off intermittent symptoms, and it was more or less staying the same. I couldn't get as much information about the aggravating factors as I would have liked because someone was having to interpret, and obviously you have a time frame to your consultations, don't you? So I couldn't really get any early morning symptoms. They just were saying at the time of the appointment that it was the same and it stayed the same. And you know, he just was now waking at night and was off work and couldn't be at work because of it. And the only thing they'd noticed, a very strange bruise had developed, even though there'd been no trauma. There's a bruise had developed on one side of his back. And again, I'd made a note that there were some issues. There was a small child, and I'd had to stop the consultation at one point. And they had to go into another room, and I called them back. We'd had to use the wife as interpreter. And as you know, we really, it's not good practice, is it, to use a family member to interpret for us or to translate things. It's much better to go through a professional interpretation service. But you know, sometimes you have to use your clinical judgment, don't you, and go with what you think's best at the time. And what happened was he'd said that he'd been getting the back pain for 2 to 3 weeks before the sickness. It was actually quite bad, and he'd gone to A&E. And he'd gone off with sickness, and they'd sent him away with naproxen and codeine, but he'd got severe, you know, low back pain. He'd gone back to A&E 2 weeks later because he'd got issues with urine. Again, I couldn't get clear on what this was, just because of the issues with, you know, interpretation. He'd had an internal examination, which was really good. But again, he'd been discharged with codeine and paracetamol and said, we're going to refer you for an MRI scan and physio. Then about a week and a half prior to my consultation, he got this strange bruising. It was on both sides and then went on to sort of one side, but he was adamant that there'd been no trauma. He hadn't hurt, he hadn't fallen, nothing had fallen onto him. He hadn't lain on a strange thing in his bed. He'd not fallen against a railing. He'd not been down the stairs. It just developed this big strange bruise. He started physio, and the physio took one look at him and said, we need to wait for the MRI. And again, he repeated that there were these issues with the urine, and he was now okay, and the hospital said it was okay. You know, there's all this stuff he kept saying, but there's still issues with the urine, and they'd given him antibiotics. So we're thinking, okay, maybe he's got a urine infection. So that's the issue. He's actually got a urine infection. But you can see this is not, we're not really clear. And one of the reasons it's not clear is because he didn't have English as his first language. But, you know, what could he do functioning? Normally, this section of my clinical notes, there's a lot more in this. But we got, you know, obviously we're trying to get people back to work. So we're thinking about their function, aren't we? What can they, what can't they do? What are their limiting factors? He had pain, you know, sort of constantly. Coding helped a little bit. He could sit for 30 to 45 minutes. He could walk without an aid, but for very short walks, but it just completely aggravated his symptoms. He couldn't use the stairs, severe pain using the stairs. And he'd been advised not to lift anything, including his child, and advised to just rest in bed. Now, again, I couldn't get clear who had advised him this. Was it the GP? Was it someone at A&E? Was it the physio? And normally we wouldn't advise someone to just stay in bed. That's not good advice for the management of back pain, is it? We want people to do gentle movement within their capabilities and some moving around, because often, as you know, muscles will waste really quickly. We don't normally want them to bed rest. So someone has identified that there may be something very serious going on here. He reported having, you know, been completely well other than this. So what happened, I did the assessment, the special questions. He didn't have neurological symptoms in his lower body. So he had neurological symptoms in his lower body. He had pain, I think, in his one of his thighs, on the back of his thigh, but it wasn't bilateral, no bilateral numbness, no saddle anesthesia. He did have the bladder disturbance. He didn't have sharp stabbing pain. He had this localized low back pain, and it did hurt if he coughed or sneezed. And then again, when I asked him about coughing and sneezing, he said on a particular day it felt like he needed to wee and he couldn't control it. He had 2 instances where he had absolutely no control, and that's when he went to A&E. That's now stopped. On 4 occasions for several hours, it stopped and disappeared. Since taking the antibiotics, it's all gone away. So he's no longer got the urine. But you can see the point I'm making is that it's not a very clear picture. Was this a bladder infection? You know, what is it? So, you know, what do you do with someone like that? Do you err on the side of the caution? He kept saying he didn't have urine symptoms prior to the back pain, and it could be that he just happened to get an infection or something at the time that he got his back pain. Maybe that's why he was getting back pain and feeling unwell. But if you look here, he had stool urgency, so he felt like he didn't have any control. So we're now looking at a bowel issue as well, and it was sort of burning when he went to the toilet. And again, it's just not a very clear picture. And so being a physio rather than a nurse, I thought, well, I'm going to err on the side of caution. He'd started to get leg pain to the back of his knee, but before we ended the consultation, he was saying it was going down the back of his leg. And then some of it was going up his back, and it was stabbing him, and he was getting pain in his ribs and pain coughing and sneezing. And this was not a gentleman that I thought was trying to ham it up, if you know what I mean by that, in the nicest possible sense. This was a man that wanted to go back to work, but he didn't know how to get better because he had these symptoms that were really disabling. So I gave him this. This is the Cauda Equina checklist that I showed you earlier, and it's in Urdu. So I went through it with his wife as the interpreter, explaining what it all said, and I sent them this as well in Urdu. So it's in loads and loads of languages. We've got lots of opportunities to share this with people. And then just this one page, very brief one here. This one was another interesting one. It's a grey area, but it's slightly different type of greyness. I don't know if that makes sense, but you'll see what I mean. 28-year-old lady, physically active, a manual job, and she'd herniated some discs and had sciatica, and that was sort of diagnosed. Just drinking my lemonade. She'd had intermittent symptoms of Cauda Equina, and her GP said, go to A&E if your symptoms worsen. So her GP had identified she had this potential for Cauda Equina. She'd been off work for 6 months, and she got referred to us for return to work advice. I saw that she'd had this Cauda Equina history. She said she didn't have it currently, but she still had symptoms of an L5 and S1 sciatica and significant dysfunction, real difficulty walking. So if anything, she still wouldn't have been able to go back to work, to a manual job with those symptoms. So I said she's unfit for work. Again, I explained to her that if her symptoms worsened, you need to go to A&E, and I explained, why that was. She got referred back to us, and she happened to come back into my diary 3 months later. She could have gone into one of my colleagues, but it happened to be me. So I read through the clinical notes again. Little bit of improvement in the sciatica, mild improvement in function, but there was this ongoing intermittency of Cauda Equina symptoms still in that last 3 months. And my clinical impression was that she was playing down those symptoms because her money had been cut, and she wanted to go back to work for financial reasons. And when I was talking to her, I could hear in her voice that she was in pain. So again, I reported that she was unfit to return to work. So this is a suspected issue. There's something going on there. It could potentially, develop. It might never develop, but if she went back into a manual job, she is much more at risk of that developing. So that's where I'm sort of suggesting to you that it's much better to err on the side of caution, and help people. We want to help people get back to work, but obviously, clients are paying if you're in my kind of role, they're paying for our clinical opinion. You know, where they want people back at work, but that, you know, we have to give them our honest opinion. So they need to understand the relevance of the questions. There's a little picture of the Cauda Equina credit card. It really is very small. They can keep it in their wallet or in their back pocket or in a handbag or something, and they can bring it out and just remind themselves, what did the clinician tell me? They told me that if these worsen or I get more than one of them, you know, a new combination of symptoms, I need to go to A&E, and I know why that's important. So just to finish, some tips for asking the questions. And again, you know, many of you listening, you're going to be, you know, experienced clinicians. So I apologise if I'm teaching you how to suck eggs here, but you might be, you know, a newly qualified clinician. I don't know. And my advice would be, when you're asking these questions about, you know, bladder and bowel and sexual function and these kind of things, just be really matter of fact about it. We want to gain rapport with someone, don't we? And there are different ways that you can elicit these questions. You all have your own ways of generating rapport with someone to help you. Don't skip any of the questions. Get clarity. It's absolutely essential. As much as you can, you know, be really just clear, and people actually really respect that, don't they? And I don't know if you've ever sometimes wanted someone to ask you a direct question, whether you've been for an assessment and they've sort of skirted around the issue or they've avoided it, and you just actually want them to ask you, does it hurt there? Or have you had a problem with that? You know, that kind of thing. Sometimes people feel almost relieved that someone's asked them. And in fact, when I've done some of the assessments, sometimes people say to me, that's the first time anyone's ever asked me that. And I'm glad you've asked me that. I'm glad you explained that. Yeah, so get clarity is essential to get the onset of the loss of bladder or bowel function, the loss of genital sensation or erectile dysfunction. The example I gave you earlier, the person that whose job put them at risk of assault on a regular basis, had some erectile dysfunction, and there were some other symptoms similar to Cauda Equina, but actually this was because of serious trauma that this person had experienced. So, for example, you might ask, how long have you been unable to feel your genital area for the last hour, the last day, the last couple of weeks? In the case of this gentleman, he said, oh no, actually, it's been going on for 5 years. This is not something that's happened since he got kicked in the back. And I thought I'd end you with this. This is the British Association of Spinal Surgeons, and this is what they say. They say a patient presenting with acute back pain and or leg pain with a suggestion of a disturbance of their bladder or bowel function and or a saddle sensory disturbance should be suspected of having a Cauda Equina syndrome. Most of these patients will not have critical compression of the Cauda Equina. However, in the absence of reliably predictive symptoms and signs, there should be a low threshold for investigation with an emergency scan. So that's their advice. So my advice is the same. If you suspect it, it's better to go and let everyone go, actually, it's nothing, you're fine. Or, yeah, it's really painful, it's a herniated disc and sciatica, and that is awfully painful, but it's not Cauda Equina. These are the references, the resources I think you're going to find the most helpful. There's a lovely YouTube video. There's a couple of really great podcasts about Cauda Equina, and there's a lovely, very straightforward, easy to read article about Cauda Equina as well. And in fact, in the YouTube video, what's lovely is it really brings home the experience of some of the people that have been diagnosed with it and why we now have the credit card system, which is because that came out, the need for a credit card with the little questions on, as a result of the questions and the feedback that we got from people who've really got it. So I hope that's been helpful. I recognise that I've talked a lot. Does anyone want to ask any questions? So have I talked you into submission?
That was fabulous. So if anybody's got
help. Yeah.
Good. I'm just wondering if I can come off my screen without losing you. So bear with me a minute. See if I can come off this screen. Wait a minute. Or in show. There we are. Oh, can you still see me? I can't see you. I don't know why.
Yes, we can.
Oh, okay. Well, you can see me. I'm sorry I can't see you. I don't know what's happened. It's this strange. Like I say, I've changed the function of my mouse and I'm not quite sure what I've done to it. Any questions? Anyone want to ask anything?
Mine was just going to be a comment, Jane, because I know that when we were setting up, if I can ask everybody to mute apart from Jane. I was actually investigated for Cauda Equina some years ago, purely due to the fact that I'd got the saddle anaesthesia, and that was coming out of the shower, drying myself and not being able to feel my backside, which was, you know, quite distressing at the time, I have to say, because it was like, you know, I'd had a back injury many years before, but these symptoms developed very quickly, and luckily, you know, I was admitted very quickly, given a scan, and they said no, it wasn't complete Cauda Equina, but just to be careful with the symptoms and to report anything. And they were particularly interested in the bowel and bladder function, like you said. So, you know, thankfully, you know, I had some really good care.
Yeah, and that is a good example, that the fact that, you know, some people have an actual trauma to the back, and then they develop it, and other people don't. It might be that they're doing repeated bending as part of their job and there's some weakness there, or we don't know. Or it could be, you know, that they've actually developed something, you know, they have a tumor or something like that, because, as you know, it's anything that compresses it. So it doesn't have to be a physical trauma, you know, like an assault or something like that, or a fall or car accident.
Indeed. We've got a question from Emma. She says, if someone reports that they have experienced symptoms long term, for example, 1, 2 or 5 years, would we still advise A&E if it's chronic?
That is a very good question. Now, I've actually had someone with that. The lady that had had surgery, she had all the symptoms.
Jane.
Can you hear me? Sorry, can you hear me?
We can now. We lost you.
Oh, I don't know why that was. Yeah, the lady that had surgery, she'd had surgery. She had the symptoms. She got taken to surgery, but she still had these symptoms. And this was a long time after the surgery. So this, and she was under a consultant. Now, I didn't send her to A&E because she was under a consultant and she was living with these symptoms. I don't know. I'm afraid I can't answer whether they could potentially get worse or whether they would ever stay the same. And in her case, the best outcome for her was from someone who is a consultant in this, and she was already under them. So I didn't refer them because she would have been given the advice as to what to do. So I can't answer that question. I'm sorry. I suppose if she wasn't under a consultant, if she wasn't under a consultant, I almost certainly would have said it's worth going to A&E. Yeah, I probably would have erred on the side of caution. And then maybe there's people, maybe there are A&E departments all over the UK think, oh my God, not Jane Johnson again. You know, I don't know. But I can't speak. I'm not sure because I tend not to have them referred into the service when they've had the symptoms for a long period of time. Anything else? Any other questions? No?
I have one, Jane.
Just another comment from me, if that's okay. Not a question, but my brother-in-law had a significant motorbike accident and was on the spinal unit up in Sheffield. He's now paraplegic, but while we were visiting him, it was shocking the number of people that were in that unit because of Cauda Equina. Just really, and that's when you say, if people say it's rare, actually, almost most of the people that were in there were because of Cauda Equina.
Yeah,
it was quite shocking.
Yeah, and again, I think it might be that I don't know how the stats are collected, but you know, certainly the number of cases. I can't be the only clinician in occupational health that happens to get a lot of Cauda Equina cases, because so many of us work with people who have jobs that are very manual. So it would be very interesting to collect that kind of data. Sorry, was someone else going to ask a question just before Janet? I thought I heard someone in the background.
Me, Jane, Pip. I was just wondering about the chap with the bruise on his back. What was the significance of that in the end, in the absence of any trauma? Was there anything that sort of led to what might have caused that bruise on the back?
That's a great question. I don't know. And he was very clear that he'd had no trauma, and he was just concerned about how it had developed. And again, you know, before I was a physio for years, I was a massage therapist, and I worked with lots of massage therapists and body workers, you know, manual, hands-on sort of manual techniques. And they would often discuss and have these kind of conversations about when the body reveals something to us and we can't explain it. So you know yourself, don't you, that you can have strange sensations on your skin when you've not actually done something to your skin. You can just have a strange, that heightens sensitivity. And you can have like when you're massaging someone, you can notice that there is a tautness in certain parts of the skin that there isn't in other areas, or there's a strange flaccidity, or one part of the skin might feel slightly warm or strange. So our body reveals things to us. Now, obviously, bruising is erythema. There's bleeding there. So why is he having this bleeding there? And again, I don't know the answer to that. I'd like to, again, it's the sort of thing that you know, that's why I'm very keen on people writing up case histories, even if it's an individual case, because you know, they can develop into a case series, you know, and that's how we collect data, isn't it? And how research moves us forward as clinicians. There's so much information out there that we all, you know, there might be someone else who said, oh, I had someone, they had a strange bruise on them. Well, there's two people. Maybe there's someone else out there where this has happened to, you know, or maybe he did have an accident and he's just simply, you know, he's forgotten, because we all know that we've all forgotten things ourselves. So, you know, we ask someone, which knee was it you had replaced? Oh, I'm not sure. Was it my left or my right knee? So it's a knee replacement. It's quite a big operation. So it could be that. But again, I don't know the answer to that, I'm afraid.
The reason I ask is my partner yesterday tweaked his back, he's a builder. Getting out of his van, just thinks he landed awkwardly. By the time he got to me in the evening, he was barely moving. So I gave him a good old rubbing, but he had a really blotchy red bruise, looked like a bruise coming up on his back, almost sort of not quite loin kidney area, but more central than that. Obviously, no symptoms of cauda equina because I checked him. But
and again, because if you think about bruising, what normally causes bruising, or what causes bruising, it's trauma to the muscle, isn't it? Either directly or internally. So the gentleman in my case, he was in a manual job with repeated bending, and he was feeling unwell for 2 weeks before he went off sick, and the symptoms got really bad. So it might be that he'd actually torn some muscles during his job, and then the bruising came out later. But because of the language barrier, I wasn't able to elicit for how long he had the bruising, which is obviously a key question, isn't it? So saying it might be that the case, you know, with your partner, that he's actually done something and torn, and that's the bleeding. It's an acute injury.
I mean, that's what it looked like. But just curious if you knew what caused it with that man.
No.
Interesting.
We've got a question from Yanis. He says, would you deny treatment to somebody that might have Cauda Equina syndrome that wouldn't go to A&E?
Oh, what an interesting question. Oh, that is interesting. Now, would I deny treatment to someone? It would. Well, what could I do with them? What would I be able to do with them in terms of treatment? I wouldn't be able to give them treatment because having potential Cauda Equina would be a contraindication to giving back exercises, because it could potentially worsen the symptoms. So I wouldn't be able to treat them. Not that I wouldn't want to. You know, just there wouldn't be anything physically that I could do. Because I'm a physiotherapist. You know, so I give advice, and obviously I do manual therapy and exercises and stability and balance and all those kinds of things. But apart from balance exercises, which wouldn't be helpful in this case, there wouldn't be a treatment that I could provide. That's an interesting question. Yeah, would you deny? I don't know.
Yanis, do you want to put your microphone on?
What sort of treatment were you thinking of, Yanis?
In the chat, he's mentioned pelvic tilts.
Interesting. Yes, pelvic tilts. Again, I give pelvic tilts for people who have herniated discs, because we want to keep people moving. We don't want to keep them still. You know, in cases of a fracture, a spinal fracture, we wouldn't want to do pelvic tilts. But again, you see, Cauda equina, it can be caused by compression from any source, not just a disc. So it might be, for example, if you had an older person or someone who didn't have to be old, but who had osteoporosis and had a spontaneous spine fracture. You can have a spontaneous spine fracture that could potentially press into the Cauda equina. So you wouldn't want to give pelvic tilts to someone who's got back pain, because that back pain could have been coming. You know, obviously you'd have a whole case history, so you'd be able to determine that potentially from osteoporosis. You know, with brittle bones, couldn't you? So I probably wouldn't give spinal pelvic tilts to someone with suspected Cauda equina. No, I wouldn't. Because
can I clarify? Sorry, can I clarify just on that specific patient that I have had in my mind?
Yeah.
So I was thinking more of a disc herniation type of Cauda equina expected. So yeah, they try to bend, young chap, try to pick something up, acute pain. You, of course, do the safety netting, and you definitely discuss about Cauda equina, but the person, I wouldn't say denies going to A&E, but he postpones that, let's say, for now. He thinks that it's not very serious. I will try again later, even though you try to definitely raise the alarm and explain to them that's an important condition. So by the time that you see them again, maybe a week or 2 weeks after, they still haven't gone to A&E. They're not necessarily worse, but you're still thinking of a suspected Cauda equina. Do you deny treatment? Or do you think that, okay, pelvic tilts are not going to cause necessarily any sort of big pressure within the disc? I'm talking about leg rolls, even just gentle advices from a physio perspective, even that is treatment.
It's a really good question. I think, you know, if I had to stand up in court and defend myself, and giving pelvic tilts to someone that you think may have Cauda equina and you know, could be at risk of Cauda equina, how would you defend that? So it's quite interesting, isn't it? Because you could say, well, actually, doing the pelvic tilts might make them better, but someone could say to you, well, but actually, you could make them worse, and the disc could then press more into the Cauda equina because they're doing the pelvic tilts. It's really challenging, isn't it? Because I love pelvic tilts. I like you, Yanis. I give them for disc herniations all the time. You know, they're really great, aren't they? An early stage rehabilitation to get the pelvis moving, when most people just want to stay completely rigid. I think that I can't answer your question. I think you'd have to decide as a clinician how safe you think that person is, and what is it that's preventing them from going to A&E?
Yeah. But I mean, based on at least on the 2 in vivo studies that we have on disc pressure, we know that pelvic tilts, either on all fours or even lying down, the pressure is much less actually than asking the person to walk. So we could say that they are very, very safe movements for a disc herniation. So one of my colleagues would tell me about denying treatment to the person, whereas I would think about carrying on with treatment regardless, carry on with safety netting, trying to encourage the person to go to A&E.
That is a fascinating topic in itself, isn't it? You know, because again, where I work in occupational health, I tend to only deny treatment if someone is not compliant with the advice in terms of the exercise advice. So I've not come across that particular scenario that you're describing with your patient, because obviously if they're not going to be compliant, then, you know, we're wasting their employer's money and, you know, their and our time. But I've not come across, it's something that I've rarely ever denied someone treatment.
Thank you.
Yeah. So sorry.
That definitely answers my question. No, it's that gray zone, and it definitely answers my question. Thank you.
Yeah,
that's what I did as well. I couldn't deny treatment. Yeah.
Yeah. No, it's a great question for, I think, to have with your peers as well, isn't it? And with a wider audience. You know, what examples are there of when we would or wouldn't deny treatment? Yeah. Thanks for asking that.
Thank you.
Any others?
Jan has made a statement, really, I believe. She says that if he has capacity, the patient is quite right, you know, can refuse treatment, but denying treatment is probably not in the best solution on behalf of the doctor, as there is no loss of trust in the patient-doctor relationship. So maybe even consider referral to another practitioner.
Yeah, that's a very good point. Yeah.
Okay. So I think that's it for questions. So yet again, Jane, thank you so much. So on behalf of IOH, we offer our sincere thanks to you. Sure, it's not going to be the last time we see or hear from you, Jane, because that was absolutely amazing. Thank you so much.
I'm glad you enjoyed it. Thank you.
So it just leaves me to say that that's it for this 2021 series of webinars. It's been our absolute pleasure. We've learned so much across the 22 webinar series that we've done. There's been some fantastic subjects, and Jane, yours is right up there with the best. So thank you.
Thank you. Oh, you make that's lovely. Thank you.
Janet's got a hand up. Janet.
Oh, I just wanted to check that we've got the link for the cards.
Oh, the link for the cards. Is it not on there?
Is it not? Is it there one more slide?
Is there one more slide? Sorry, let me have a look. Yeah, hang on. Oh, that's the charity. I'm sorry, I didn't put them on there. I will find it. Yeah, it's from the Charter Society of Physios in Musculoskeletal Health. That's where they come from. I'm sorry I didn't put that on there. God, that is remiss of me, isn't it? Thanks for pointing that out, Janet.
What we'll do, if Jane sends us the slides, we can put those up onto the IOH website. The recording will be on the YouTube channel, so the IOH YouTube channel. Hopefully later on today or early tomorrow, that will be up. But again, thank you very much, guys. I'm wishing you all a fantastic Christmas. Please take some downtime. It's really important that you recharge your batteries and refresh yourselves. It's been a really challenging, very, very challenging year. And hopefully, with a bit of luck, you'll be able to recharge and get going ready for 2022. And let's see what challenges COVID brings for 2022. I hope it's nothing too bad. But let's watch that space. Thank you very much, guys, and good evening.
Thank you.
Thank you.